And so I would now like to welcome our next speaker, Isabelle Audo, who's going to discuss Dr. I Can't See in the Dark and retinal structure and function. And Isabelle is a professor of ophthalmology in the Department of Genetics at Vision Institute in Paris. And her exceptional clinical research has expanded our understanding of genetic mechanisms of inherited retinal diseases, coupled with electrophysiology, and is paving the way for new treatments. So thank you, Isabelle.
Hello, my name is Isabelle Audo. I come from Paris, Hôpital 1520 and Institut de la Vision. I want to thank Graham Holder and the SOE for inviting me to this interesting seminar. And I'm going to talk about Dr. I Can't See in the Dark. So here are my disclosure. None of them are relevant for this presentation. Night blindness is sometimes a symptom that is overlooked, especially in our modern cities. There are various causes, very few being treatable, but they need to be recognized to appropriately be managed. One needs to distinguish between common symptoms that are not degenerative, especially night adaptation disturbances in case of moderate to high myopia, especially if it's poorly refracted, or difficulty to dark adaptation linked to aging. Regarding causes of dark adaptation abnormalities, there's usually a genetic disorder, which is much more common, but also acquired disorder, which we'll review in this presentation. When managing a patient with dark adaptation, the first step is to take medical and personal and familial history, looking for causes of malabsorption, restricted diet, GI surgery, chronic diarrhea, chronic cholestasis or cirrhosis, history of cancer or inflammatory condition or medication. Associated symptoms including light sensitivity, photopsias, decreased visual acuity, or abnormalities of the visual field, especially the side vision. And of course, asking for a family history and other cases in the family with a pedigree that should be drawn. Then follow an ophthalmic examination with a careful refraction, especially for myopia, but also a careful look at the presence or not of a nystagmus or fundus alteration. Kinetic visual field test and dark adaptometry may be helpful, but however, the key examination when dark adaptation is the chief symptom is full-field ERG. And this full-field ERG recording should be performed at least with the minimal ISF standard recordings, especially with this period of dark adaptation of 20 minutes at least. Then this full-field ERG will be followed by retinal imaging, and the two key multimodal imaging that are very important are fundus autofluorescence and SD-OCT. We will now review the different causes of night blindness or dark adaptation alteration. Far more are the most common are genetic condition, and the first one that to fear are degenerative. The most common cause of dark adaptation with retinal degeneration are rod cone dystrophies, also known as retinitis pigmentosa, where the fundus can be typical with pale optic beads, narrow blood vessels, and pigmentary changes. However, these pigmentary changes can be missing, especially in early stage of the disease or in case of high myopia. There's associated disorders that are affiliated to retinitis pigmentosa, such as those three disorders associated with chorioretinal atrophy, choroideremia, with this lack of pale disc, vessels become narrow with advanced stages, but also this large chorioretinal atrophy. Piety crystalline dystrophy is another cause of chorioretinal atrophy or gyrate atrophy, a very rare disorder with this patchy scalloped atrophy from the periphery, usually associated with high myopia and early onset cataract. Another key feature of rod cone dystrophy and affiliated disorders is on the full field ERG, the primary photoreceptor involvement with a severely reduced A wave under dark adaptation condition, which predominate compared to the photopic responses, which are usually a bit more preserved, at least when the full field ERG is still detectable. There's another very specific disorder, which is called enhanced cone syndrome, which is usually mixed with the retinitis pigmentosa, but should probably be distinguished first because the visual prognosis is a bit different than retinitis pigmentosa, and second because there's some very specific ERG features. The fundus can be variable with little dots that are hyperautofluorescence, or when there's pigment migration, it's usually nummular around the vascular arcades. And one distinguished feature, which is very common, is also the presence of cystoid maculopathy, which actually is important for the visual prognosis. The full field ERG reveals very distinguished feature. First, there's no rod function under a dim light stimulation, no B wave are detectable. Then, if you look at the response to a bright flash under dark or light adaptation, the waveform is quite similar. And actually what is happening is that the scotopic responses are dominated by cone responses, but these cone responses are abnormal. You can see with this very deep A wave and slow B wave compared to the normal response to a single flash under photopic condition, but also the flicker response has an amplitude that is below the amplitude of the A wave to a single flash, which usually actually the amplitude of the flicker should be between the A wave and the B wave of the single flash. This is very characteristic, but if you are lucky to have the possibility to do short wavelength stimulation, you can see that unlike a normal subject, the response to a short wavelength stimulation would be very, very large. And this showed you that there's an enhanced response to or at least to short wavelength stimulation. So enhanced cone syndrome is a recessive disorder linked to mutation in this transcription factor called NR2E3, which is really critical for rod differentiation. When NR2E3 is mutated, there's no rod differentiation, and by default, all the retinoblasts that were supposed to give rods are actually differentiation in S cones, so there's an excess of S cones. Other genetic condition will be more stationary and also with normal fundus, except some affiliated disorder. So congenital stationary night blindness can be distinguished into two subtypes, the Rix types and the Schubert-Bonstein types. The Schubert-Bonstein is by far the most common. That's why I'm starting by that. What happened in the Schubert-Bonstein types is that there's a transmission defect from the photoreceptor to the bipolar cells. Therefore, on the ERG, the A wave under dark adaptation is normal, originating from hyperpolarizing bipolar cells, photoreceptor cells, upon light stimulation. But the B wave is severely reduced, giving an electronegative shape to the response, and really showing that there's a signal transmission defect from the photoreceptor to bipolar cells. Miyake in 1986 further distinguished Schubert-Bonstein type of CSNB into two subtypes, the complete and incomplete, based on the response to a dim flash under dark adapted condition. The complete form doesn't have any B wave, where the incomplete has this reduced and delayed B wave, but still present. The response to a bright flash under dark adaptation is similar, with the normal A wave, severely decreased B wave characterizing the electronegative ERG with the B to A amplitude ratio inferior to 1. Complete and incomplete can be further distinguished based on their photopic responses, showing this for the complete, this relatively preserved amplitude delayed response, but this characteristic square shaped A wave with sharply rising B wave. And when possible, long duration stimulation in the complete form will show selective on defect. So the complete form has no on response under dark adaptation condition and no on response to light adapted condition, which mean this is really an on bipolar defect. The incomplete form, however, has more severely affected photopic responses. And when performing long duration stimulation, both the on and off pathway are severely abnormal. Interestingly, the phenotype is slightly different. The complete form is more typical with possibility of transmission as an X-linked or recessive trait, night blindness, nystagmus, strabismus, high myopia, and normal fundus, except for myopic changes, whereas the incomplete form is a bit more variable, mostly X-linked. Actually, night blindness can be overlooked, and the patient may complain more about light sensitivity. Nystagmus and strabismus are usually present. The refraction is a bit more variable. Myopia can be present, but maybe less commonly than for the complete form. Fundus abnormalities include, of course, myopic changes, but there's some cases of macular abnormalities that have been reported. Interestingly, all the proteins that are involved in incomplete CSNB usually localized at the photoreceptor synapse, therefore impacting both on the on and off pathway, whereas the complete form of CSNB is associated with mutation in proteins that localize the dendritic tips of on bipolar cells, both rod and cone on bipolar cells. Beside this Schubert-Bronstein type of CSNB, there's another type. It's the Riggs type, which is by far the least common and least characterized. In these cases, the primary defect is on rod photoreceptor. So there will be on the full field ERG under back adaptation condition, both a decrease in A and B wave amplitude, and most of the proteins that are involved in this Riggs type of CSNB are actually implicated in the phototransduction cascade of rod photoreceptors. This is an example of the ERG that you can get. No B wave under to a dim flash under dark adaptation. The A wave is severely reduced, but also the B wave, and we will come to that. In fact, cone photoreceptor function is preserved, and in these cases, dark adapted responses are actually dominated by cone responses. And we may see this pseudo-electronegative ERG because under dark adaptation, when this is a cone-dominated response, you can reveal what is called the Photopic Hill phenomenon, which is a balance between the depolarization of the on bipolar cells and hyperpolarization of the off bipolar cells, with this push-pull phenomenon and this tension, this different tension that really characterize the cone system, giving this pseudo-electronegative ERG. Aside from this CSNB with normal fundus, there's other type of CSNB with abnormal fundus, such as fundus albipunctatus, characterized by these little white dots. This is a recessive disorder linked to RDH5 mutation involved in the retinoid cycle. In these cases, similarly, cone response are preserved, whereas a rod response are altered. But if you do a longer dark adaptation, then you may recover normal rod function. The other very rare disease is Oguchi, with this very typical goldish fundus, which disappear upon longer dark adaptation. Aside from this genetic disorder, there's also acquired disorder, and probably the most common is vitamin A deficiency, which may be associated with a poor diet, liver condition, chronic diarrhea, and so on. In the fundus, the alteration may just be subtle white, yellowish presenoid lesion. And regarding the functional alteration, vitamin A deficiency is characterized by preserved cone function, but isolated rod dysfunction. Another frequent cause of acquired night blindness are inflammatory disorders, such as this posterior uveitis called Burchard corneal retinopathy. And actually, the group of Moorfield with Professor Holder really nicely demonstrated that when at the acute phase, Burchard corneal retinopathy is associated with inner retinal dysfunction that will resolve upon a treatment, and the ERG may be quite instrumental to follow and manage this patient to document a generalized retinal dysfunction at the level of the inner retina to monitor this patient. And I want to finish with very rare conditions such as paraneoplastic syndrome, carcinoma-associated retinopathy, which is a primary photoreceptor defect, or MAR, or melanoma-associated retinopathy, which really resemble the complete CSNB with both rod and cone on bipolar defect in the context of a melanoma. So the take-home message, as you see, there's a lot of causes of night blindness, and they are not only synonymous as retinitis pigmentosa. Full-field ERG is very instrumental. It will document the dysfunction and also precise the diagnosis. Acquired disease may be recognized as well, and they can also be monitored by performing repeated full-field ERG, especially in the management of Burchard corneal retinopathy. And I want to thank you for your attention.
Thank you very much, Isabelle. That was a lovely, comprehensive view of the rod retina. We've got some speaker here, so I have a rather question. So to all the speakers, do you ever perform any examinations out of the ISEP protocols? Why and when? So Isabelle, do you?
Yes, I do. Actually, it's not very easy when you have a busy electrophysiology clinic, but I do think to get more deeper in the phenotyping of some of the disorder, especially I demonstrated for enhanced cone syndrome or for congenital stationary night blindness. If you want to definitely document complete and incomplete, you may do additional testing. But I must say, already in the ISEF standard, you have some hint of this disorder.
Okay, thank you. And now we have another one from Anthony Calcadney. Considering vitamin A deficiency in the early and intermediate stages gives a cone-isolated retina, why do you think it sometimes comes with visual field defects?
This is interesting. And actually, it's to me, it's a recent questioning because I just recently saw a patient with vitamin A deficiency. I do think that, you know, when you perform full-field ERG, you mostly test peripheral cones, and maybe Graham can also comment on that. And maybe there's some subtle cone dysfunction that you're not capturing with the full-field ERG that you may see with static perimetry, for example. But I do think this is something that occurs not in the early stages, but probably in the intermediate stage when the vitamin E reserve for cones are also starting to win, I would say.
Can I come in there?
Yes, yes.
No, I think that's correct. It doesn't occur in early vitamin A deficiency, but if you take somebody who's been chronically vitamin A deficient before they get beta spots and not that severe, that you will find when you actually treat the patient, there will be a slight improvement in cone ERGs. So even though the ERGs were cone isolated when first tested, and those cone ERGs can fall within the normal range, they still will probably show some improvement. So there is some loss of cone sensitivity. The cones, of course, have access to the fast recycling through the Muller cells that the rods don't have.
Thank you. So, gosh, lots of questions now.
Yeah.
So this is good. In the complete form of CSMB, why don't we see an A wave in the dark adapted dim flash?
Well, actually, I don't think we are supposed to see an A wave in the GA 0.01 ERG because you're so dim that obviously you have stimulated some of the rods, but your technique is not sensitive enough to detect the A wave. So even in a normal patient, so I'm not expecting to have in a normal patient an A wave, but just the B wave because they're amplification of the signal at the level of the unbipolar cells. But so therefore, I don't expect even in complete CSNB. Mm-hmm.
Okay, so it's just below any threshold.
Exactly.
Okay, and then we have another. Is dark adaptation curve mandatory in any of these conditions?
So mandatory is a strong word. I think, to be honest, in a busy electrophysiology clinic, I don't do dark adaptation curve. But I do think when you're looking for a precise rod sensitivity, it would be really, really interesting. I don't know if you and Graham have some feedback for that. You may want to comment.
Graham, would you like to join?
It's a difficult question for me to answer because I currently don't have access to it in Singapore. But while I was at Moorfields, what we found particularly useful was not just having straightforward dark adaptometry, but also dark adaptometry which tested dark adapting cones as well as dark adapting rods, which was a system which was developed by Chris Hogg and Jeff Arden. And that enables the detection of a disorder known as when you lose the inhibition. Usually what you've got is as the rods start to dark adapt, they suppress the function of the cones. And then the cone thresholds increase. And you can get a phenomenon called enhanced rod-cone interaction, where the patients actually usually present with glare, with driving, et cetera, but they have completely normal electrophysiology, completely normal anatomy, usually. But you can pick it up using dark adaptometry, providing you look at cone thresholds as well as rod thresholds.
That's very interesting. So that the trigger would be that you get that interaction.
If the interaction between the rods and cone system is great, hence the enhanced rod cone interaction, the elevation of cone thresholds, which usually would be a log unit plus, goes up to 3 log units, sometimes higher.
Gosh, that's very interesting. Thank you.
Described by Jeff Arden.
Excellent. Okay, so these are moving fast. There is one here which is about anybody having experience of using Retinal portable ERG devices and what we think about it. Have you used it, Isabelle? Do you have a?
I've never used it. I'm very happy with my standard ERG, my full field and so on. So I wouldn't like to use it. I don't feel the need.
I think this is very true, actually. We do get very used to our own equipment and know its foibles and how well it works, don't we?
Yeah.
I think maybe this is something we might answer, or we could express answers offline for this, because I think we're getting close to the end of questions, I think. So thank you very much, Isabelle.
Thank you. Nice.
Lovely talk. Thank you.